love to clap.
Yes. That's our signature move. Remy,
It is, Dr. Shant.
what are we talking about today?
Two very, very filthy words, which, I mean, when I say, I almost have to preface it. I'm like, oh, watch out, I'm going to say them. But the big A word, activation, and inhibition.
Yes, that's a big one, isn't it?
Yeah, massive.
Yep. So, how many times have you seen, social media is a fun place, isn't it? How many times you've seen on social media someone saying, if your clinician has said you have knee pain because you have weak glutes, that's a bad clinician.
You know what? It's not even just how many people, it's also the pedigree of people who say it. I mean, we're not going to name names, but accounts with millions of followers, well-respected clinicians, sports scientists in the field that will go out and say that. And it's like, oof.
Yep.
You're missing a bit of context, but
Have you heard something similar like that?
I've heard specifically that.
Yep.
Yeah.
Yep. And then another one is the weak core and glutes as well.
Yeah, weak core, weak glutes. They seem to be the two. It's actually always those two.
Yeah.
I never really hear it too much with shoulder presentations. It's always seems to be just the core and the glutes, and then they'll say there's no such thing, and you wouldn't be able to stand up if that was possible. And I think the biggest differentiation, which we'll chat about now, but I try to make with my patients, is that there's a big difference between strength and skill. They're actually, it's a dynamic relationship. They're very closely interrelated.
Yep.
But strength and then proprioception, your body's ability to tell where it is in space and then coordinate muscles, and that coordination, neuromuscular control. And movement patterns are very complex. And when someone comes to us with an issue, usually it's an issue associated with a specific movement pattern. So it's never as simple as weak glutes.
Nope.
It's never as simple as a weak core. We know we move in different planes, right? Forward, back, side to side, we twist around. So it's interesting how, and we're going to go into all these different principles, and you're going to talk about the background history of inhibition, but how they all interrelate, but really differentiating between saying you have weak glutes, that's a dumb thing to say.
Yeah.
Right? It's almost negligent. It's almost like it's basic.
Yeah.
We're going to break it down.
So if your clinician just simply saying you have knee pain because you have weak glutes, probably an idiot.
Yeah.
Because it doesn't have any context.
Correct. Yeah.
Right? And the dirty word, inhibition, maybe we start there.
Yeah.
So the most common criticism of the word inhibition is, well, if you can stand up, your glutes are not dead or they haven't gone on holidays. Well, that's not what we're saying. Firstly, why the word inhibition? It's a standardized medical or clinical terminology developed and accepted and taught across the field of neuroscience, neurosurgeons, orthopedic surgeons, neurologists, because it's been accepted almost 150 years ago.
Yes.
Right? It's a terminology that they have accepted and standardized. And as clinicians and practitioners, we have to use standardized terminology. Like, why do we call this supination and why do we call this pronation? Because that's the clinical terminology.
Yeah, is what it is.
And if you just start calling things random, names, then no one knows what the other person is talking about. So the terminology, the word inhibition, it's established terminology in the field of medicine and neurology and neuroscience.
Give us a little bit of a short background on that.
Yeah, so
where that came from.
One of my favorite books that I had to read early on from Andrew was by Lord Sherrington, or also called Sir Charles Sherrington.
Yeah.
He was a neuroscientist, a neurologist. Because of his contribution, he even won a Nobel Prize, right? And he coined two of the most common terms that we use in our clinical practice, which is reciprocal inhibition and arthropogenic neuromuscular inhibition.
Yeah.
And he also conceptualized further in the terms of proprioception, what you have explained.
Yep.
Right? like I said, he won Nobel Prize for it.
Yeah.
If you talk to a neurosurgeon or a neurologist, they're very aware of it.
Yes.
When we use the word inhibition. Further in the field of neuroscience, and even in the research of tendinopathy by Jill Cook and Ebony Rio, the terms cortical inhibition, corticospinal excitability comes in. Again, standardized terms. So these terms are used as medical terminology, and we have to explain them with the context. For an example, with Lord Sherrington's reciprocal inhibition. If my biceps contracting and my tricep is also trying to contract, I'm not going to be able to do a bicep curl. It's just going to be an isometric hold and extension, right? When my biceps are contracting, my triceps need to be inhibited for that movement to happen. So what the nervous system is doing, when the bicep starts to contract, because we have made a conscious decision to contract the bicep, it notices a subtle stretch in the tricep muscles, and it will inhibit through the interneurons to suppress the excitation to facilitate that bicep curl.
Yeah.
Meaning, this is contracting, I have to relax the opposing muscle group to facilitate that movement.
Yes.
Reciprocal inhibition. Another one is arthropogenic neuromuscular inhibition, which is when a joint is either injured or the nervous system detects a threat, it goes in flexion. The body is trying to create a natural sling to shorten that joint as a protective mechanism.
Yes.
So whenever people hurt their shoulders, the first thing what they do, they curl up and they just lock everything up, right? They can't get all the big ranges of motion they would normally get. It's a neurological phenomenon through arthropogenic neuromuscular inhibition.
Yes.
Anterior femoral hip pain, same thing. Because there are some dysfunctions and the body's detecting a threat, it's over-engaging the hip flexors to shorten that muscle, which is pulling that femoral head forward.
Yep.
And that's also creating pain, and we talked about pain before.
Yes.
Right? So the reason we are using that word inhibition, we are not saying something is dead. It's not saying there's absence is in neurology. It's quite the opposite. It is a neurological phenomenon that is controlling and organizing that joint in the best, safest way possible, determined by the nervous system. Right? So if your clinician hears the word inhibition and then they're just writing it off as, oh, you don't have dead muscles, good chance your clinician does not have a very good understanding the history and in-depth understanding of neuroscience.
Spot on.
Yep.
Spot on.
All right. Now, inhibition is not a bad thing. It's part of the nervous system's organization process.
Absolutely.
However, like we said, there's inhibition in reciprocal inhibition, which is facilitating a movement, or we have arthropogenic neuromuscular inhibition,
Correct.
which is a protective mechanism that can corrupt our movement pattern.
Yes.
Right? So I know you copped a lot of flack for, using banded activations.
Yeah.
Yeah? Let's go into that a little bit.
Yeah, so I did. I cop a lot of flack for using banded activations, and even some patients that I see, they'll say like, "Oh, don't tell me I have sleepy glutes," and I know we just spoke all about that. Now, this derives us into our phenomenon of PAP.
Yep.
Right, and PAP, arthrogenic neuromuscular inhibition, all these concepts, they kind of work in this almost sphere, this circle. It's like they all interlink with each other.
Yep.
And the way that we describe PAP is a specific phenomenon or an increase of neuromuscular activity when a specific motor pattern or a specific muscle has been worked and isolated and contracted. And we know that this works because we know that muscle remembers its contractile history. And the reason why we use the activations and this principle of PAP, and I'll let you delve further into the science, you're probably a little bit better at explaining it than I am. But the reason why we do that is because if someone comes in with a problem in a movement pattern, and a movement pattern which is multi-plane, which requires all these different moving parts. We need to be able to strip that back and go, with our assessment, we identify what are you missing, how are we going to get there to improve the contribution to what's missing, and we have to break that down to its lowest form and take the step to then get to where we want to get.
Yeah.
So using that PAP response with our activations, if we can improve someone's hip extension by accessing abduction, by accessing external rotation, whatever we find in the assessment, then that is what layers the movement pattern on top of each other and allows us to access a new range or access a movement pattern and facilitate it moving better.
Yeah, and that's a very, very, very important point, that you drove across, which is banded activation is not the only thing that we do.
Oh no.
Right?
No.
It's a ladder.
Yes.
Step 1, step 2, step 3, step 4.
Yes.
They fall into a specific step depending on the clinical presentation.
Absolutely. One thing, and one thing that you said, Andrew said, always stuck with me. There's no such thing as a bad exercise or a bad activation. It's the right thing for the right person at the right time. And that's why assessment is so important. And that's why even the order of how we progress activations is important.
Yep.
It's all very, very specific to the patient.
Yeah. And it's not like we're just putting a band on the person and just get them to do random things.
No, man. No.
It starts with our subjective, which is identifying the person's problem, identifying the person's goal, a very in-depth history of that person's movement patterns and injury mechanisms, and the goal of the person, what they want to do. If somebody wants to be a powerlifter, what their body demands is going to be very different than somebody who wants to be a sprinter.
Oh yeah.
Right? So the starting process may look the same, but that's not where we stop. We start with the activation, and then we integrate that activation motor pattern into a more complex movement pattern until we reach the top of the ladder.
Yes.
Right? So I'll use you as an example. When you first came to see me, there were some very specific deficit. I just didn't say do this activation and then, all right, go home now.
No.
We got all the way from very subtle, activated, directional movement pattern to you competing in a powerlifting meet and winning the competition.
Yes.
It was a full process.
Well, I mean, we use the example because I would get pain when I'd walk.
Yeah.
It got to that point, my injury severity, where I was pushing through lifts and it was now causing a problem in daily life. But my problem that I came to wasn't the fact that I'm in pain when I was walking. Like, I could live with that. My problem was that I had to pull out of a national competition because I couldn't squat 50 kilos off my maximum without being in severe pain.
Yeah.
That's why I came to you. I came to you with the goal. I came to you with a specific movement dysfunction with a specific movement pattern. We worked that all the way back.
Yep.
From the start.
Yep. And that's the neurological phenomenon of activation, right? You are very extension intolerant. Let's create a hypothetical scenario.
Yeah.
Right? If I go straight into extension work, it will provoke pain. And yes, pain is a very good piece of information, but that's not what we're trying to fix. We're noticing that extension is causing pain. And we want that extension to come from your hips because that's where you create the most amount of torque at the hip joint.
Yeah.
However, the muscles that create extension, the group of glute muscles, they're also responsible for doing abduction and external rotation,
Yes.
which you could tolerate. So this is the beauty of neurology. If you excite a muscle in a direction which falls within the category of the functions that it performs, the other functions get better.
Yes.
So by getting you to do abduction and external rotation, your extension got better.
Yeah.
Once your extension got better, then we can start creating a squat pattern. Once your squat pattern got better with the activated muscles that we have created, now we can start putting some load on it.
Yes.
So now you can learn how to handle the weight again.
Yes.
And we made subtle changes to your technique as well.
Oh yeah.
Right?
Yeah.
Because organizing movement, and this is the big takeaway of Lord Sherrington, is your nervous system is an integrated system, right? It's not one thing in isolation. We may start at isolated point, but it's integrated. We are weaving a thread of this now connects to this, now this connects to this. And the pathway may look slightly different to each person, but the goal is to get them to their end point, where they want to go.
Absolutely.
Right? And when it comes to the knee pain, right? If you're just saying that there's knee pain because you have weak glutes, you're wrong. But if we add some context to it, then it makes sense.
Yes.
All right. The knee has only one function. It bends and straightens, right? It's one function, but just different directions, right? That's the only thing it knows what to do. The knee does not bend sideways. It only bends forward and backwards. Where that knee is going to go is determined by your hips. And you said, we have all these different muscles within the hip joint creating that angle.
You've got something like 21, 22 different muscles in the hip.
Yeah, you have all your abductor
everything.
groups. You have your hip flexor groups. You have your hip abductors and extensors and rotators.
Yeah.
And other, even within that, you have other stabilizers like your piriformis, you have your QF. So they're all working together from the hips to direct the knee where they needs to go. Now, if you're not moving in the right mechanical pattern, of course, you're going to create stress concentration in your knee, and your knee is going to hurt.
Yes.
But it's just doing one thing. It's bending and straightening.
Yes.
Where it's going, how it's behaving, is determined by the hips.
And that's why if someone comes in and says, I have knee pain, going back to the start, it's like, yeah, I'll look at the knee. I want to assess that mechanically we're cool.
And we want to make sure that it's structurally okay for us to do what we need to do.
Structurally, it's okay.
That's important.
But most of the time, that's going to be somewhere else in the chain. And the hip being the most dynamic joint, hip and shoulders, right? Ball sockets, tend to be, a lot of the time, a big part of the cause, the reason why.
Yeah. So back to the point of activation and inhibition, sometimes inhibitions is necessary to accommodate a movement pattern. But when it's disrupting a motor pattern, that's when we bring activations in, not to just activate the muscle in isolation. And I would let you go more into the EMG stuff. We're trying to create a movement pattern or a motor pattern with the muscles we are trying to activate. But we're stripping it back down to a segmental level to start building the process in the clinical setting. If somebody doesn't have any pain, discomfort, no one's going to come to see me or you.
Yeah.
People come to see us with a problem. We do the movement assessment and we recognize.
Yes.
And back to the point of EMG.
Yes.
Let's go a little bit into that.
Yeah, I think the problem that stems with me for this one is that a lot of people in research will say, or at least modern clinicians, stuff that I see online, the research shows that you can't not be activated because there's still contraction of the muscle. And if you have the muscle, if there's a nerve innervating it, then it's contracting. And I think my problem with this, and why I'm using EMG specifically, is because just because a muscle is innervated by a nerve which is functional, or you've done an EMG test and it's coming up that the muscles is creating an electrical pulse from contraction with activity, is not the same as what I was going back to the start as coordination, proprioception, putting a movement into a skill. These are different aspects. So you might not be weak, but if it's a coordination issue that causes a stress concentration further down the chain in the knee.
You're weak in that coordination.
Correct. You're weak maybe in that plane, in that coordination. Maybe your glute max is strong. Yeah. If I got you to do hip extension and I put a force plate, or I said the word before, but I'm forgetting about it, but any sort of device that enabled or measured dynamically force, it might show very strong. It might show, okay, the right side is pretty even to the left side, you're good, so it can't be a problem with your extension. But then when you actually observe the person doing it, what's taking over? Well, the hamstring's working really hard. The lumbar erectors are firing super hard. So maybe we don't have a weakness in a certain movement, but we have a coordination problem,
Yep.
other things which are working too hard. It's deeper than just strength.
Yes.
Strength is, and macro strength is separate from everything we talked about, proprioception, coordination, all that stuff, sequencing.
Yeah, and a general way to explain strength, and this is, Andrew always used to drive home, what is strength? Strength is a skill. Somebody who's a very good powerlifter, they're very good strong at doing 1 rep max in squat, bench, and deadlift.
Yeah.
Somebody who's a very strong runner, they're very good at putting some serious times in their marathon.
Oh, specific.
Right? One is not strong in the other. And that is what we're talking about, the macro strength of that person within that skill.
Yes.
However, when they have symptoms, we assess and we identify within that strength where the breakdown or dissociation or lack of coordination is happening. And we start creating activation, targeting that. But the goal is always to integrate that back into that movement pattern.
Yeah, the goal is let's try to turn the signal up in the brain on that movement pattern, then let's put that into the thing which hurts you.
Yeah, and another great research from Jill Cook and Ebony Rio, I think Ebony Rio has done more research in this specific field of cortical inhibition and excitation, is corticospinal excitation, using transcranial magnetic stimulation, right? It's a magnetic thing, measures the waves into the motor cortex, and then you can, translate that into proper information.
Yeah.
Okay. When there's pain, there's also inhibition. By doing isometric activations, the pain symptoms has gone away. They did not target the pain. They have targeted a very specific movement pattern in isolation, in isometric. Immediately, they were able to create more voluntary muscular contraction. Okay, now that we can do that, let's go back to the task. You're a basketball player and you want to be able to do your layups. Good. This is your activation before you get your game.
Yeah.
And now you do that before you go back to your practice.
That stuff, some of that, I mean, specifically the isometric you talked about and the pain.
Yeah.
Very important when we get to our tendon presentations, which we'll come back to in another episode.
Yeah.
I know you're an expert on that.
Yes, but the point is, we did not just get fixated on the pain.
No.
Yes, it reduced the pain, but it also increased the muscular activity.
Yeah.
And it reinstates that voluntary contraction of that muscle, which allows them to go back to doing what they want to do. And in majority of the cases, the clients, the athletes, whoever it is, they have no interest in which tribe we belong to. They just want to have their problems fixed.
Yeah.
And this is something we talked about in our very first episode. It's winning a social media argument is not our goal. But the reason we're talking about these two words is because we want to really create some defined distinction between what they are and the context of what we're trying to explain. So inhibition doesn't mean something is switched off. Activation doesn't mean you're bringing something back from dead. We are playing with neurology. Now, if you deal with somebody who's paraplegic, there's no need for activation because there's no neural feedback going back to the system. No banded activation is going to fix that, right? That's where the gene therapy and the stem cell therapy and all that comes in, because they're structurally trying to change something in physiological sense.
Yeah,
okay.
Different process.
Nothing wrong with that. In that case, activation is invalid. No point trying to do that. It's the same way, if you do not explain what the glute is doing with the knee, there's no point doing activations because you're doing a shotgun approach, throwing a bunch of things at it, hoping something sticks.
Yeah.
Right? So the takeaway I would say from this episode would be understand the terminologies. Inhibition is a clinical term coined by some of the best neurologists of our time, and it's an accepted medical terminology that we use. Activation is exactly the same. If you just type in PAP and PAPE, I think we need to make a separate episode on PAP and PAPE because that gets, creates another set of arguments.
Definitely.
But we're not going to be able to do that in a few minutes.
Yeah.
It's that understanding the definition and the context of inhibition and activation is very important before you start writing something off as, oh, it's just weak glutes. That's rubbish. If it's just weak glutes, yeah, it is rubbish because you haven't explained anything. You haven't given any context.
The neurology and movement is so much deeper than weakness.
Yeah.
Yeah.
All right. I think we've covered what we wanted to cover on this one.
Yeah, I think so. That was good.
All right.